All right, for those of you who are watching, and I hope there are a lot, welcome to Internal Medicine Grand Rounds. Because of the COVID virus situation, this is the way we'll be doing Grand Rounds for the foreseeable future. We don't know how long that's going to be, but we won't be having live Grand Rounds. We'll be having streaming Grand Rounds. And so today we're lucky to have some experts to talk to us about the COVID-19 situation, and they are, as you can see on the slides here, from our institution, from ARUP, from Primary Children's Hospital. I'll introduce them in just a second, but I want everybody to know that if you go to Slido, you go to slido.com and then enter the number 5645 for this event. You can then ask questions, which will come to the speakers afterwards, and you can see questions that other people are asking, so you can say, yes, I want to hear the answer to that question. So throughout the presentation, you can be asking questions, and at the end of the presentation, we'll take those questions and pose them to the speakers, okay? Well, we're lucky today to have some distinguished speakers. We're going to hear from Andy Pavia, who is the Chief of Pediatric Infectious Disease from Primary Children's Hospital, from Jeanmaria Mayer, who is the Chief Epidemiologist for the University Hospital, from Sankar Swaminathan, who's our Chief of the Division of Infectious Disease, and then also Dr. David Hillyard from the Department of Pathology, who is the Director of Molecular Infectious Disease Testing at ARUP. And I think with all of those people giving us a talk, we'll get a good overview. So let me turn it over to you, Dr. Pavia.
All right. Well, thank you, Dr. Bjorkman. Thank you for joining us virtually for this. Most of us have been going flat out for the last couple of weeks, and this was put together on the fly. So hopefully, if you have questions that we're not answering now, we will know more in a couple of weeks and maybe do this again. But I'm going to start by giving a broad overview. Which one do you? Let's see. That's me. Of the epidemiology that we know so far about SARS-CoV-2 and the disease known as COVID-19. This slide shows a picture of people in the street wearing masks, which we know don't help. This is Seattle, but it's not this week. It's actually from 1918 during the last pandemic of worldwide significance, similar to this one. Now, we've known for a long time that we were just waiting for a pandemic to come. This is from a talk I gave as a vice presidential lecture in 2004, and I quoted Ed Marcuse, "The clock is ticking, but we don't know what time it is." We were forewarned. We're not necessarily forearmed, but now we have to deal with where we are today. Let's go back in time and talk about the timeline of this event as we know. As we understand it so far, this is from the official Chinese government view of what happened as published in the New England Journal of Medicine. There may be some smoothing over of rough spots in this account, but I want you to focus on the left side of this slide. At the end of November, the beginning of December, cases of a SARS-like illness were seen that were not connected to the seafood market that was initially blamed for it. And with an incubation period of about 5 days, we know that this illness must have begun to circulate sometime in November or the end of December. Once we got to about the 28th, the Chinese government, or rather the government of Wuhan, recognized that there was an outbreak and activated case finding. There was national notification a couple of days later, and the Wuhan seafood market was closed, and that was thought at the time to be the epicenter. There were some amazing accomplishments that you see on the right side of the slide. By the first week of January, a sequence had been isolated that looked like a beta coronavirus, closely related to a bat coronavirus. Within a few days, a PCR had been developed, and the sequences were shared online with researchers throughout the world. That's the good news. What hasn't really been talked about so much in the Chinese official circles is that there was recognition that something was going on earlier, and it wasn't talked about. This is Dr. Li, an ophthalmologist who, on the 27th, said on social media that he thought SARS had come back. I think everyone knows the story. He was arrested. He was released and allowed to go back to work. He contracted COVID-19 and he died. This is the virus. it's already been sequenced, it can be grown in culture, and we're learning a great deal about it. When we turn to the epidemiology, it's been really quite remarkable. This map shows the temporal spread over the first 5 weeks in China, and it began as a focus in the city of Wuhan, a city of about 15 million people spread throughout the province, and as you can see, it reached every province in China within a matter of only 5 weeks, and you can see that many other foci of a lot of disease were there. If you haven't already found this website, it's terrific. This is the Johns Hopkins GIS Mapping Daily Report. This is madly out of date because I think I loaded it about 8 hours ago. But it tells you roughly where we are with about 125,000 confirmed cases, 4,500 deaths. I want to focus your attention, I don't know if this pointer shows up, in the lower left corner, which shows you the number of cases in China and those outside of China. So the number of cases that are being found outside of China now far exceeds those that are diagnosed in China. And then if you look at the map itself, you see why this has been a pandemic for quite a while, regardless of the official declaration. The entire northern hemisphere has fairly intense disease locally with some community transmission in many countries, and the southern hemisphere is beginning to show up. And we'll come back to the southern hemisphere a little bit later. This is the situation in the United States as of about 4 a.m. this morning, so it's out of date, particularly the Utah numbers, but we're at something as of right now at about 1,300 unconfirmed cases. CDC only counts them after they have redone the confirmation. Every state, aside from 3, has cases, and the 3 that don't have cases, or 4 rather, including Maine, do not have very robust testing or public health. In the bottom right, you see the epidemic curve that shows new cases diagnosed per day. And I think everyone realizes that this is not the spread of the epidemic so much as the spread of test availability. We're not surprised to see this, and this will only increase more rapidly as testing becomes more available, and you're going to hear about that. So I've been dealing with pandemic preparedness for a long time now, and we thought we were in good shape in 2009, but one of the things we learned very quickly was that you need to know the severity of a disease to know how many triggers to pull and what kind of control measures are appropriate. So CDC developed this pandemic severity matrix that looks on the bottom axis on the nominal measure of severity, and on the y-axis on transmissibility, and you see kind of the range for seasonal flus. You see some bad flus in there. You see the 2 pandemics of 68 and 57. 1918 is out as sort of our mother of all pandemics, and SARS and MERS very lethal but low transmissibility. So where would we put COVID-19? CDC doesn't have an official position on that, but we have looked at that a lot and been in discussion with them. So this is the Pavia version of where it falls. We think that it's somewhat more transmissible than 2009 swine flu, and the lethality probably falls somewhere between the 1968 flu and the 1957, and I'll talk more about lethality in a minute. Let's talk about the basic epidemiology for a second, and this will be brief, so if you don't like epidemiology, don't let your eyes glaze over. But it's important to think about the R0, or the basic reproductive number, in the absence of control measures, immunity, or vaccines. And it's estimated now from a number of studies pretty robustly to be somewhere between 2.2 and 2.5 patients will be infected by each person with the disease in the absence of control measures. R0 changes or the actual R changes as we do things to control it. The incubation time is a median of 5 days, ranging from about 2 to 11, with an outside at about 14 days. And this leads to an epidemic with a doubling time unchecked of about 4.5 days. One of the things we're just beginning to learn from beautiful work being done in Singapore and Hong Kong is the secondary attack rate. And in very good studies of households with large numbers who are all being tested, in the household 10 to 15% are positive. So it's not that high. And among other close contacts, it's only 1 to 2%. Nonetheless, this is enough to drive an epidemic forward. The age distribution is really important to us as healthcare providers, looking at the impact this is going to have. These are data from China, looking at Wuhan, Hubei, and the country as a whole. It's a little bit difficult to read, but this peak here is 50 to 59-year-old age group, and then the substantial number of the hospitalized and diagnosed cases are in people older than 60. What is really important to me as a part-time pediatrician is that only about 2% of the cases that were diagnosed were in children under 19. But that's China, and we know that case finding there may be skewed by the size of the epidemic and by medical practice. Korea did a beautiful job of ramping up their testing. They tested 25,000 people in the first few weeks. So there we have a much less biased picture of the epidemic. And again, we see that the cases on the left are skewed towards older people. But now you see that there's a large number of cases in 20 to 29-year-olds as well. On the right, though, you see the deaths. And the deaths are predominantly occurring in people over 50. There are no deaths in people under 20 years old. And in China, there was only one death out of 72,000 cases in a person under 20. There are a lot of nice papers on signs and symptoms. I want to show it in a graphic form in the interest of time. Fever eventually is seen in 80 to 90%, but it's only present at presentation in 50%. Cough is present in about half, myalgias, arthralgias. Headache, less common, and diarrhea occurs occasionally, somewhere to 5 to 10%. These different bars represent different parts of China. This graph is a little bit different in that the different colors represent mild, moderate, and severe cases, or rather mild, severe, and critical. About 80% of cases so far have been mild or moderate, not requiring inpatient medical attention. About 15% severe, requiring hospitalization, and about 5% requiring more significant life support, ranging from high flow oxygen on up. And what you can't really read that well on this slide is that if you look at the gray bars for the critical illness, the vast majority are occurring among people with underlying illness, hypertension, diabetes, cardiovascular disease, lung disease. Missing from here are any details about cancer or about children with chronic conditions. But this is a disease predominantly of older people and a disease of people with underlying conditions. I'd like to have more time to talk about the clinical manifestations, but one of the most important things for us to recognize is that the X-ray findings on CT are quite recognizable, and this is just one of several papers showing the ground glass opacities that are quite typical. Moment on case fatality rate. What is it? We don't really know. You've heard a lot of nonsense from people who are suddenly epidemiologists talking about it. The true rate is unknown because we don't know the denominator and we have to worry about right censoring. But in Korea, where we have pretty good numbers on the denominator, the crude case fatality rate so far is only 0.65%. Only 0.65%, but that's still about 6 times higher than a typical flu season. In China, outside of Hubei, it was 1.4 crude. With modeling that accounts for right censoring, it appears to be about 0.9 to 1%, and it has gone down over time, as shown in the graph at the bottom of this slide. I'm going to finish up with some points that were made by a group of really outstanding epidemiologists and public health doctors in Singapore, Hong Kong, and Japan. And one of my old mentors, Keiji Fukuda, was one of the authors of this. The title is Coronavirus in Singapore, Hong Kong, and Japan, Lessons from Highly Functioning Health Systems. Do you feel the jab in our ribs there for having a less than highly functioning healthcare system? So here are the lessons they took away. Rapid adaptation of surveillance systems, rapid scale-up of testing, selective use of travel restriction, moving away from those quickly, early and effective coordination across all arms of government. They shifted the cost of clinical treatment to the government so all people in their countries had access to care. They developed plans to sustain the healthcare system so our other functions could keep going in the face of the outbreak. They actively managed their supply chain. They emphasized infection prevention and protection of healthcare workers, and I should point out that these countries have a more robust supply of infection preventionists and ID docs than we do, and they train more of them. They have interoperable IT across healthcare systems that aided in coordination, and they pointed out that they had effective communication from trusted authorities in public health and government. You're hearing a lot about mitigation. So where is the future taking us? This is the strategy that's driven our pandemic planning for many years now. And the idea is that when we can't treat a disease and we don't have a vaccine, we need to spread out the impact on the healthcare system. Because if we have a rapid surge, as shown in the initial hump, you cannot handle it in the healthcare systems that exist. So if you slow the spread, slow the acquisition of disease, you buy time, you allow the healthcare system to have beds available, and hopefully you also have vaccines and drugs available that we're going to talk about more in a minute. Can it be brought under control? Well, with the right circumstances, it appears that it can. This is the epidemic curve so far from Korea as of about a day ago, showing that the number of cases is declining after their very rapid and comprehensive countrywide control efforts. And I think a lot of this was clinical control and not drastic measures like shutting down cities. Where will it go from here? What you can see here is the rate of rise in many countries looks unaffected by control measures. But if you look at Japan, Singapore, and Hong Kong, the rate of rise was much smaller. We are up here right now among the uncontrolled groups. Will we be able to reproduce this? And I really hope we will. What's going to happen in the next couple weeks? Nobody really knows. We don't know if this will behave like influenza because it's not influenza. But we should keep in mind that with influenza pandemics, there are typically waves. And in the 1918 pandemic, the first wave in the spring was relatively mild, and it came back in the fall much more severely, leading to many more deaths. And that is certainly one of the possibilities as to how this will play out. So I'm going to stop there and turn this over to Dr. Mayer.
It's not, how do I move it if it's not? So it's not advancing for me. It's not advancing for me. So where do I push? Oh, okay, here we go. Okay, so I'm going to...
The mouse isn't working, I'm getting my brother up.
So can it not go to slideshow?
Yeah.
So I'll just go ahead and start and do it in whatever form I can do it this in. So I'm, as the Chief Medical Epidemiologist at the University of Utah Health, I'm going to give you sort of a local application of how we're responding to this with our infection prevention and surge preparedness for COVID-19. So this is from the CDC, and the CDC has put out the pandemic intervals, and this is something that we sort of brushed off our pandemic respiratory viral plans. And as you can see that we have some time in terms of when we investigate and recognize that we have a new viral pathogen, and then we also start to have trigger points where we implement different
Keep going.
where we have different interventions that we implement throughout this period of time. And as you can see, that big spike during the acceleration, that's when we go into overdrive. And I'll just go over some of the things that we're doing at the University of Utah Health in terms of preparedness and response. So we expect to see extremely high volumes in our ambulatory settings and emergency departments. So for that, we have to really be able to immediately identify individuals with a respiratory illness, mask the source patient is extremely important, and then isolate them, get them away from other individuals. There's a huge plan to do virtual visits and have patients call in so that they're not coming in physically to our ambulatory settings, and then also do things like drive-through testing. There's also, looking at our personal protective equipment protocols and doing extensive training with our faculty, trainees, and staff. Diagnostics are quite important, as Dr. Pavia mentioned before. The other thing that we're looking at constantly is our supply issues. So during times like this, there's often a run on supplies. If you've been to Costco's lately, you can just imagine that the same way that there's a run on toilet paper and water at Costco's, there's a run on personal protective equipment, hand sanitizer, and disinfectant for healthcare systems. If there's a vaccine and antivirals available, then we work on how would we prioritize those. The other thing we look at is where are we going to cohort, where are we going to have patients in our inpatient care locations. And then some of the things that we do as well is look at a bed board and our respiratory care situational awareness, once or even twice a day when things get heated up. And then we also have triggers that we would then go on to different surge actions, so such as a trigger to when we would limit elective surgeries. We also need to anticipate significant reductions in staffing, so whether staff are actually ill or they're fearful or there's other things that just prevent them from coming to work, such as they have children at home and schools are closed and they need to stay home with their children. So we have plans in place to try to reduce the barriers for some of our healthcare workers, doing surveys to see what we can help them with to keep them at work, try to expand our PTO policies. And we also try to encourage things for social distancing, so if individuals can work remotely from home or to do things like we're doing today with virtual meetings, so that healthcare workers are more heavily exposed, have a higher risk. So if you have a group of healthcare workers together, there's a greater risk of just exposing each other. The other thing that we do is we start to look at lockdown. So we lock down parts of the facility so it's harder to get in. We will screen visitors or do restrictive visitor policies so that we're looking at people coming into the building. Are you sick? Can we reduce just the number of people coming into the building? And when you get to that peak, if we're really just getting a surge in our healthcare systems, sometimes we also need to implement crisis standards of care. So the Utah State has put out a crisis standards of care, and there's a lot of input from multiple physicians across healthcare systems. And this was last updated in June of 2018, but again, this is now being revised as we speak. And it's a large document that goes into our activation algorithms and goes through a stage that across the state, if healthcare systems are feeling overstressed, that the Utah Department of Health and the governor could declare a state of emergency that would enable us to enact crisis standards of care. So that may be that we're running out of ICU beds, we're running out of ventilators, we don't have the staffing to take care of our patients. So then we start to prioritize and triage care. So some of the things that we're doing at the University of Utah, and you may have seen this outside of our building, is on the slide to the right, we have in place and ready to go actually early next week to change the traffic and patient flow so that we can limit access into the building and have a better sense and be able to control and screen visitors and healthcare workers as they come into the building. We also have set up a pre-triage tent in front of the emergency department area. So the plan would be as individuals come into the system, will we have a surge, people want to get tested for SARS-CoV-2, even though we try to keep them at home. Are there more individuals coming in ill? So it will be a very, very quick pre-triage where there's a look on the patient, and then if they have respiratory illness, they will be diverted back to another area. If they're critically ill, have chest pain, an MI, PE, they would go into the regular ED or other non-respiratory illnesses. So when patients are triaged and if they have a respiratory illness behind the university hospital where the emergency department ambulance area is, we have two very large military-grade tents set up that are negative pressure, and it's basically like a MASH unit. And you can see on the right-hand side that there are sort of bays in that tent that are set up, that the chairs for the patients are at least 6 feet apart to give us that airspace, and there's partitions and there would be PPE within the tent. I'm going to switch gears now and just sort of talk a little bit about how healthcare workers, how we can protect our healthcare workers. I think that's really the main concern that I'm hearing right now from our faculty, house staff, staffing. And similar to what Andy Pavia presented earlier, this is a recent MMWR report that gives us an idea of what the attack rate is. So this was active monitoring of individuals that were exposed to confirmed cases of COVID-19. And there were about 450 people with close contact to 10 travel-related cases, and they were monitored over time. So there were 19 individuals that were in the same household. 5 of those stayed in the household during the incubation period. There were about 200 community exposures, and then about half of the rest were healthcare personnel. So 54 or 12% of those that were considered close contacts actually became symptomatic within that 14-day period and were considered persons under investigation. However, out of that, only 2 household contacts actually tested positive for the virus. So that, again, very similar to what Dr. Pavia showed before, about 0.5% among close contacts and about 11% of household contacts. There were an additional close to 150 individuals that were exposed to the 2 patients that had the COVID-19 that developed symptoms. None of those individuals turned positive. So with this small cohort, there was no sustained person-to-person transmission among close contacts of the first 10 individuals that had travel-related COVID-19. Just a little bit about the transmission and the mode of transmission. So with SARS-CoV-2, it's really felt that the primary mode of transmission is droplet. And then also we have to worry about contact as well in terms of contaminated surfaces or contaminating ourselves. So if you look at this diagram on the right, you can see that the large red blobs are what we consider the droplet. So droplet are large respiratory droplets that are greater than 5 micron in size. As an individual coughs and sneezes, they expel that out, and if you happen to be right in the line of fire, within 3 to maybe 6 feet, if you're in that line of fire, then you're potentially exposed if your mucous membranes are, if you're inoculated. These droplets do not remain suspended in the air. They drop like lead balloons to the ground, so they're not floating in the air. And if an individual inhales these, they don't reach the alveoli. Whereas organisms that are airborne transmitted, such as measles or tuberculosis, are small droplet nuclei. So these respiratory droplets dry out, become small, they're less than 5 microns, and they stay suspended in the air and float. These are the organisms that will float out of the room and down out into the hallway. So those are airborne. So again, SARS-CoV-2 is felt to be primary route of transmission is droplet. So with that said, what's just the right personal protective equipment for most of the clinical care that we would provide to an individual with SARS-CoV-2? So here's an individual who's coughing and sneezing. You can see these lovely large droplet. So here's what we see in pictures from China, or this was from Africa with Ebola. So we're getting ready for the zombie apocalypse with all of our PPE that covers every inch of our body with the high-level respiratory protection. So really with droplet nuclei, what's most important is that we use contact precautions as well as the droplet precautions with the just regular surgical ear loop mask. And it's very important to also protect our eyes, because you can imagine if you're in front of those droplet nuclei, if your eyes are inoculated or if you're touching your face, you could potentially contaminate your conjunctival membranes. The other thing that's quite important, and we sometimes forget about this, is that we have to be very careful with cleaning our hands, hand sanitization, to help with that contact and when our hands get contaminated and then we inoculate ourselves after. So in most scenarios, the just right personal protective equipment is, okay. Now, with that said, I think there's often frustration with what PPE do we wear. We get frightened. We want to know what to do. We want the training. Well, part of the problem is things keep changing, and we need to be flexible. So the CDC and the recommendations that we get often are changing, so that changes, and also our PPE supply sometimes change as well. So I want you to notice that 2 recommendations, the infection prevention and control recommendations, and also the recommendations for how we handle exposed healthcare workers, they keep changing. They were just updated this past week, so it's hard for us to keep up with the changes, and then after a while we sort of settle down and we know what to do. So at this point, we're settled down and we know what to do. We're actually following the lead from University of Washington. University of Washington is in the middle of their epicenter, so we're kind of looking to them. So right now, they are just flooded with patients, and they're finding that what works the best is droplet contact eye protection for most clinical settings. So when you're thinking of the patient, the type of interaction you're having with that patient, if you're in an ambulatory care setting or even on the acute care wards, for the most part, it's droplet contact eye protection. It gives you the appropriate PPE for non-critically ill individuals. It's consistent with the World Health Organization guidelines. It allows us to save more of our PPE for when the patient, if that patient gets more critically ill in the ICU with aerosol generating procedures. So if you're in an area where there's a patient is having intubation, bronchoscopy, CPR, you can imagine there's more aerosols. And in those situations, then we go to airborne contact and eye protection. What the CDC says is, if you happen to have a negative pressure airborne isolation room, go ahead and use it, but it's not required. Again, it's not an airborne agent. And I'm just going to finish off. We've been changing the pulse page. It's been updated. We're going to be looking at that again, and if it's confusing, we'll change it up, and that's it.
Great, thank you. So I'm going to speak briefly about the virology of the virus that causes this disease and try to correlate it with some of the potential treatments and touch on what the mechanism is that we might hope to see with various drugs that'll arrive. So coronaviruses are widespread in the human population, and prior to SARS and MERS, most of them caused relatively benign respiratory illnesses, and these have been circulating in the human population for hundreds of years in some of them. SARS and MERS are both beta coronaviruses, as is this novel coronavirus. The SARS-CoV-2 is thought to be derived from bat coronavirus, as were the previous 2 strains that found their way into the human population. The current novel coronavirus has a major divergence in the spike protein, which are those structures that you see that give the virus the appearance of a crown, which gives its name of a coronavirus. So there's a major divergence, which is unique in this virus from the previous viruses in this spike protein. And this is actually what the virus uses to bind to the receptor on human airway epithelium, which is the ACE2 protein, the angiotensin converting enzyme 2 receptor. So, and as Dr. Pavia pointed out, this has been sequenced in incredibly rapid fashion by the Chinese, and the structure of this protein has been solved. They made this protein in bacteria already and have crystallized it, and so we know how it looks like. We know where it looks different from previous coronaviruses, and we understand that this different area is actually where it binds and enables it to enter the human cells. So these are single-stranded RNA viruses, and this actually has relevance to its life cycle and drugs that may be used to combat it. So because it doesn't have DNA as its genetic information, but rather RNA, which encodes and is translated into proteins that the virus needs, including its viral coat and that spike protein I was talking about, it makes one large protein from that messenger RNA, from that RNA genome. And that protein is then cleaved into multiple individual functional proteins by a virus-encoded protease. And this includes structural proteins like that spike protein, but also because it's an RNA virus and we don't have enzymes that can replicate RNA, the virus has to make its own RNA polymerase to replicate its genome. And that's another, therefore, therapeutic target. So this cartoon of the virus shows you those glycoprotein spikes. I guess this pointer doesn't work, but you can see the yellow glycoprotein spikes sticking up out of the viral envelope. And this enzyme, this polymerase, is actually quite accurate, unlike many RNA viruses, which generate a lot of mutation as just part of their error in their replication of the genome. However, coronaviruses are actually quite faithful, quite accurate, and there's not a high mutation rate because they have a proofreading enzyme that fixes those errors. However, the reason that coronaviruses are in fact mutable and can change their properties of transmissibility and virulence and also allow them to enter other species has to do with the fact that they recombine quite readily. And that's because this replication polymerase can jump from one genome to another and incorporate pieces of another genome into the first one. And this is from Dr. Barrick at University of North Carolina, and we used to think that way that these viruses got into our population or into other mammalian species was by a slow process of evolutionary mutation, so that you get a rare random mutation that makes it a little bit better at maybe binding to the human receptor, a little bit better at replicating in the humans, and then, or in a civet in the case of SARS, and that a process of accumulation of mutations led it to become more and more adapted to the human host. And remember, we have different receptors from bats and other species, so to enter our cells requires a good bit of molecular change. But study of bat coronaviruses has led to a different and probably correct hypothesis, for which there's a lot of data, is that bat populations are actually multi-species. So they, in those huge, collections of bats that you see in contagion movies, there's different species, and the coronaviruses that have evolved in bats are actually quite a heterogeneous species to begin with. So those viruses are quite multifaceted and multipotent because they can infect different species, because those coronaviruses in bats are recombining with each other. So they've got species that can interact with your ACE2 inhibitor or your DPP receptor or your DPP4 receptor. So they've got a lot of these generalist strains that are sort of jack of all trades pre-existing in bat populations. And so you can see here, shown in red, right up there, is the new novel coronavirus, and its closest relations are a bat coronavirus, and that bat coronavirus was actually isolated from bat feces in Wuhan in 2013. So we don't think it went through a process of slow adaptive mutation, but rather that it just found its way into either an intermediate host or a human, and it was really quite well along the way of being able to replicate in humans, and so now it's taken off. So how does this relate to potential treatments? Well, that RNA-dependent RNA polymerase is a unique target because it is not a human protein. And remdesivir was originally developed as a potential candidate for treating Ebola, which also is an RNA virus, and it causes chain termination. It inhibits that polymerase and keeps the virus from not only being able to replicate its genome, but make more RNA from which it can make protein. And it was inferior in Ebola in randomized trials that they did, and the monoclonal antibodies and other combinations appeared to be more effective. But now it's been repurposed. It potently inhibits SARS, MERS, and the novel coronavirus in vitro in cell culture. It prevents the replication of those viruses in human airway epithelial cells. But in addition, it's been shown to work prophylactically and therapeutically in both mice and primate models with SARS. So it's already in clinical trials abroad and through the NIAID in Nebraska and I believe in Washington, where most of the U.S. cases have been treated. And 2 Gilead trials are set to open very shortly, in which less severe cases will also be enrolled and studied. Now, I should mention that because of that limited availability of these trials, they're not going to be widely available. They're probably going to be at a limited number of sites. We have asked them to consider us and given them the information that we would need, but it may be that they will go to the sites that have the greatest number of cases currently. Now, I spoke about that spike protein, and this is what engages the receptor. And most viruses evolve to engage receptors that have to be present on their target cell that they're tropic for. And it not only binds that ACE2, but it has to get in. And to get in, that spike protein has to be activated to enable fusion with the cell membrane. And to do that, it requires a cellular serine protease. And this was just published last week. This actually was known that it requires this type of activation, and is required for fusion of the viral envelope with the cell membrane so that the virus can gain entry. And this was published just recently that not only is this cellular TMPRSS2 protease involved in novel coronavirus entry and fusion, but it's inhibited by this drug, this small molecule. And if you inhibit that protease, the virus may be able to bind, but it won't be able to get in. And they were able to actually show that it prevents spread in tissue culture. And in the past, it's a very limited study, this drug seemed to inhibit entry in a mouse study. This is actually, interestingly, licensed for use in Japan for completely unrelated reasons, but it's not available outside of that country. And this is sort of the basis for why chloroquine may have some effect. It increases endosomal pH in cells and inhibits activation of proteases in a more general way, and therefore may interfere with the function of not only the receptors, but may affect the entry of novel coronavirus. Lopinavir boosted with ritonavir is the HIV protease inhibitor, and the rationale here is that it may inhibit coronavirus protease, which is required for cleavage of that viral polyprotein to generate functional smaller proteins, as I was talking about. Now, the clinical role of this remains to be determined, and I must say that, the previous published results with, I believe, MERS were not particularly convincing or cause for enthusiasm. And I think the reason is that these proteases get bound up by all the proteins that we have in the body. And the reason that they work against HIV is that the HIV protease is exquisitely sensitive to these inhibitors. Nevertheless, it potentially may have some clinical utility. So important reminders about this is that these potential therapies are not proven. The ones other than the ones that are in clinical trials, which also is not proven, remdesivir, is completely off-label use and would really be considered only as sort of a last-ditch salvage effort in case of progressive disease, after careful consideration of whether this would be beneficial. Also, there's a very limited amount of chloroquine. We have some, but only some. And so therefore, these drugs used off-label for this indication will be restricted. And if you think that there's a situation where this might be appropriate, we'd like to have one channel for the management of this. Please contact Antibiotic Stewardship, and they will be happy to shepherd you through the process if it's appropriate. I just wanted to say, all of the people in ID, pediatric ID, and hospital epidemiology, and so on, have been working together. And some of the things that we've done with the solid organ transplant group, we have worked with them. We have a patient information sheet to answer their specific questions of what they can and can't do or should do, and also guidance for the providers. We're in the process of generating similar guidance for other immunocompromised patient groups, and we'll make those available through electronic links on our website. We have just started an ID pager for COVID-19 questions regarding testing and therapy, particularly for inpatients. And the person who's going to be carrying this pager today wanted me to remind you that this is really just for questions about testing for providers and not to be given out more broadly, because it will then rapidly become impractical and will have to be shut down. And finally, I just wanted to say I've just been so grateful for the incredible selflessness and team spirit that's been shown by everybody over the past week, that even though we haven't had a surge in patients, they have all just pitched together and had to deal with all of the questions and trying to get these protocols and other preparations in place. All right, thank you.
Hello, my name's Dave Hillyard, and my role in this outbreak has been to lead the team that's been working so hard at ARUP to get a COVID test up and orderable through ARUP. And so today I'd like to give you some background on testing, and I want to just begin very briefly with what the process is that you have to go through to get an orderable test. So on February 4th of this year, the FDA issued what is called an emergency use authorization. And for those of you who aren't familiar with this is a process that allows us to get tests up very, very quickly, but not go through the regular FDA process. On February 29th, 2020, there was an amendment to this that really had a fantastic impact and has done probably more than anything to open up test capabilities around the country. So this is a document that streamlines the process. It focuses on determining limits of detection, specificity, testing samples to make sure that we do not have false positives in a very, very responsible way, but tremendously shortens the time. This kind of approved testing is only applicable to CLIA-certified high-complexity laboratories, for which ARUP clearly falls into the category of. So when you've heard about COVID breaking out, and when we knew it was doing this, that, and the other, and sort of hints at when it would be a big challenge here in this country. And so we've been tracking this also. And so in the middle of January, we started deciding what our pathway forward would be. And our decision was to team with a large company that would eventually release an EUA with a very, very high test capability. So through the latest EUA guidelines, we used REO reagents from our colleagues at Hologic Diagnostics and validated this document that you can see on the right here, through using this in this document, and the fact that we have fully validated is now up on the FDA page. So this allows us to have a immediate and fairly large capacity, and I'm not going to get into specific capacities because it's very, very dynamic. But I want to let you know that part of our strategy in going this way was because we would foresee much, much greater capacities on instruments that could do high volume testing. So again, I can't give you specific information, but I'm very, very optimistic that potentially as early as next week, we will have access to very, very large numbers of test kits, which of course everybody is talking about now. Who's got the kits? When are we going to be able to have high volume testing? Also to let you know, we have been looking for Plan Bs and Plan Cs and Plan Ds. And I can tell you now that one of our Plan Bs has gone through the same process, and should we need to use it, we would be able to test using that modality. Now, a critical question is, how good is the test? And that's a long story, but I'll just tell you briefly that this is a test that uses the polymerase chain reaction, same technology as the CDC assay. Like the CDC assay, it targets more than one target. In this case, 2 open reading frame 1A targets with an internal control. And of course, we want this kind of targeting because there will be mutations, there will be polymorphisms, and if one of the detection targets fails, we will be able to pick it up, hopefully, with the other target. So this chemistry has been fully vetted with the FDA and BARDA, and only 2 days ago, in fact, as referenced here at the bottom of this slide, there was a statement that the first large-scale COVID-19 diagnostic tests were getting federal advanced development support. So we're very confident in this test. The platform is equally important. We have done testing on a platform called the Panther for some time for targets like HIV, hepatitis C, hepatitis B. Some of you have seen results from that platform. What was achieved just a few months ago was a capability to use a fusion module, literally called the Fusion, which allows for PCR amplification and detection in a real unique mode, and one of which that is very, very relevant to the current situation. So through a process in which nucleic acids and the samplers are extracted once and amplified many times, we have been offering a respiratory panel, a respiratory virus panel, or RVP. And so as samples come in, it's important to know whether patient symptoms can be related to influenza testing. So we have been doing this already in the context of the outbreak. What's nice about this, also out of one extraction, we can amplify in the same run COVID testing. So I know there's not a lot of time, so I'm going to just cut to the chase. Ordering is important. Testing's now available under this EUA process. The capacity, we are very confident, will rapidly increase. I want to literally read this very important information for specimens. It's changed a little bit. Some of this is in response to saving the number of test kits, but the specimen should be a nasopharyngeal swab and an oropharyngeal swab. Should place both of these swabs in one collection tube, but if we receive just a nasopharyngeal swab alone, we will process it. And then another important note is that this same NP-OP swab can also be used for COVID and RVP PCR. So turnaround times. I've changed this slide so many times, even today. So we don't want to overpromise and underdeliver. I will tell you that the theoretical limit for this is to have a sample go on the machine and get a result back in about 3.5 hours. More practically, we're talking about 24-hour turnaround. But because it is a random access instrument where, in the context of a large set of samples, we can move a key stat sample to the front of the line, in situations like that, we would have the capability of doing that. So this information has appeared or will shortly appear in the test directory. It echoes what I just showed you in the previous slide. And I just want to finish with one final comment and that is that we are going to have increased test capacity, but we really need to encourage individuals to follow guidelines for testing, to be very, very judicious in what they order. We're a very large institution with clients all the way around the country, and if everybody just at the same time worried that I might have COVID-19 and I need to send a sample off, we would be overwhelmed, any lab would be overwhelmed, testing capacity in America would be overwhelmed.
From this room.
Questions? So we'll be answering questions from Slido. There was one question not on here that we wanted to ask, and that was who qualifies for testing?
Jeannie, are you sending up the criteria?
I know that,
You need a microphone.
There you go.
So the ARUP testing criteria, I know that several clinicians got together and developed criteria. So basically, it's any patient in the outpatient or inpatient setting, if they have a fever or symptoms of an acute respiratory illness and have an exposure. So they were exposed to an individual with laboratory COVID-19 within the previous 14 days, or they were in an area of widespread COVID-19 transmission. And then the other is we want to be very careful with our hospitalized patients. So hospitalized patients that basically have a fever and signs and symptoms of a lower respiratory tract illness that's otherwise unexplained. So you have a patient with ground glass opacities on their x-ray and they test negative for flu and other respiratory viruses would be up for criteria. And I think there's also some liberalization of that at some point. And the other thing that we want to do is save it for healthcare workers that need testing as well.
Okay, pass the microphone, sorry. So this is a question that was voted on the most. If we have a cold, throat irritation, sniffles, etc., as a clinician with no travel exposure, are you recommending we stay home and cancel clinic?
Luckily, we passed that back to you.
That's a great question, and that's actually being looked at now. So at this point, up to this point, we really are not aware that we've had widespread transmission within Utah, and we've really focused on those high-risk travel areas, but we know that it's sort of all about us, and at this point, what I would say, and I'll check in with Dr. Pavia as well, that if we have any healthcare worker that is ill, that we do request that they remain home. So
our recommendations are primarily going to be a little bit different. We're very concerned about the workforce. As soon as we know we have enough testing available for healthcare workers with symptoms of a respiratory infection, we're going to try and get them tested. We'll keep them home until they have a negative result, but if they don't have COVID-19, then we will let them back according to usual guidelines.
The next question, with Murray School District closing, others likely to follow, how does UUHC plan to deal with the loss of workforce in wake of these closures?
So that's also something that our HR and work wellness group have been working on. Nursing set around a survey to sort of identify what are the key barriers for folks to come to work. So that's one of the issues is there other childcare arrangements that could be made? Are there individuals that could work remotely from home? Trying to look at seeing if folks can do cross-training. So, and it's recognized that there's going to be some shortages in healthcare workers. That's one of the issues is, schools getting closed and childcare arrangements.
Lest anyone get the wrong idea, don't pass a cup around like this. We're all going to sanitize our hands.
Okay, I'm about to take a slug out of it because there's really half an inch of bourbon in the bottom. So the policy recommendation from the Lieutenant Governor's Task Force was to delay school closure until systems could be put in place to do that safely and more effectively. It appears that, from what I know so far, that the Murray School District kind of went out on their own on this, and perhaps they will reconsider.
Any evidence or details about the specific risks to pregnant women?
That's probably for me. So There's very sparse data on pregnant women so far with this virus. With influenza, we all know that pregnant women are at higher risk of severe complications, particularly in the third trimester. The data that we do have from China and South Korea does not suggest that we're seeing the same kind of big increase in ARDS among pregnant women that we have. I think that you still have to consider that in the third trimester, pregnant women have decreased vital capacity and immunosuppression, so we would be concerned that at least in late pregnancy we may see some more severe disease. This is one of the urgent questions we need to have better answers for.
We only have about a minute left. I don't know how much longer we're going over, but just keep going. One more minute, one more question? Okay. What is the COVID-19 assay test? Is it PCR test, DNA sequencing, antibody-based? What is the sensitivity? This may have been discussed already, I'm not sure.
Yeah.
Is that one discussed already?
Yeah, just to refrain, it's
Go to the next one.
Okay, yeah. Next one?
Yeah.
Can I talk about quarantine? Quarantine? Sure. Is that a question on here, Dr. Milne? I guess just talk about quarantine. I don't see a quarantine question.
Like for healthcare workers or for patients?
Is 14 days necessary? It sounds like Dr. Lee is saying we're going to up healthcare workers to get tested earlier, prioritize them so they get back to work. If someone's exposed.
Can you repeat the question?
Yeah.
Sure. So the question is about quarantine and exposure. And let me just say that for people who are symptomatic, a negative test is highly reassuring. For people who've been exposed who haven't yet developed symptoms, testing doesn't give you an answer. So if you were providing medical care at the University of Milan to COVID-19 patients, a negative test doesn't help us out until the incubation period is passed.
And I think some of the issue, too, in terms of quarantine or when we would furlough employees really depends on where we are in the, at the stage locally. So once we have widespread transmission in Utah, then individuals could be exposed at work, they could be exposed at home. So at this point, we really had been quarantining anyone that had a high-risk exposure, say a travel exposure. We'll be switching at some point in the near future to, if you've had an exposure, that we may have you work until you feel poorly. So it would be like active individuals would be asked, every day to check their temperature and symptoms, and then once they feel ill, they'll be asked to stay at home. I'm looking at protocols that will develop in terms of when we would test individuals, and from what I've seen from like the University of Washington site, they, once someone tests negative, they ask that individuals stay home for 72 hours from symptom resolution, is what, from what I heard.
Which is
72 hours.
72 hours, yes, it's different than the flu, and that's why it's important to get that test for healthcare workers, so that we know it is SARS-CoV-2 and not, say, the flu. Okay. Does that
Can you
answer?
repeat I think Jeanmaria and also Andy's answer to healthcare worker who develop some cold symptoms? Did you say they stay home until the test is? Who should be tested among the healthcare workers?
So what we would ask is that if a healthcare worker is ill and they're going to stay home from work, that they need to call Work Wellness, and Work Wellness will be contacting individuals. And one of the things that I'm also doing today is seeing if I can get additional help, anticipating that we'll have more calls, more sick calls.
These are the people without fever, though, right? Just the cold, maybe kind of mild to moderate runny nose and some cough. We can have a lot of people staying home. That's what I'm concerned. Yeah. Okay.
I think that might be, yeah, why don't you answer that question as to
I'm going to
mild?
have Andy maybe answer
So-
that.
I mean, at least as we think about this, in the setting in a week or two when we have lots of testing, we know that many healthy young people will have mild to moderate symptoms. Only half will have fever at the beginning. So that's why I think if we use testing, we can keep our workforce intact and take care of our patients.
That's it? Okay, that's it, I think. Thank you all. Thank you all for tuning in.